the end only. I'll request Professor Vijay Kher to take over.
On a regular follow-up, we found that a creatinine had gone up to 1.4, which used to be somewhere around less than 1 milligram at that point of time. And the urea was also gone up. TAC levels were 5.6. We did an ultrasound Doppler, showed normal flows. There wasn't any obstruction at that point of time. So we are very aggressive people who do biopsies in such a patient. So we did a biopsy in this patient, and lo and behold, we found that this showed interstitial inflammation with some tubulitis along with SV40, which was positive. We did a blood BKV PCR, and the copies were more than 100,000. 100,000 copies. So this was a patient who had BK virus nephropathy with no acute rejection was considered in this patient. Interstitial inflammation in these patients many times, which will mimic like a picture of interstitial along with tubulitis also. But usually if you have a associated SVV40 positive, then it would be predominantly a BK virus nephropathy. So as was mycophenolate mofetil was stopped, we continued this patient on tacrolimus and steroids. And 2 weeks later, the serum creatinine was 1.4. You had gone down a bit. BK virus in about a month's time had gone down by 60%. At 3 months, the copies kept on going down and it became negative. 1 year post BK virus PCR was negative. Renal functions improved to a creatinine of 1, urea of 36 milligrams. She was continued on TAC and prednisolone. I usually do not sort of bring back mycophenolate mofetil in many of these patients because actually CMV and BK virus nephropathy, if it develops, tells you about the native net immunosuppression of the patient. And if it only tells you that this immunosuppression is more, and therefore we need to continue to give it on the lesser side. So I usually continue with tacrolimus and prednisolone. In an occasional patient, we might have to bring it back, but otherwise, usually mycophenolate mofetil, she didn't receive it post BK virus, and 6 years post transplant, I saw her only on 16th of June, and the creatinine was 1 milligram, urea of 30 milligram, and she's doing extremely well. So the questions which arise from this case is actually that how common is BK virus nephropathy in kidney transplant recipients? What are the risk factors for BK virus nephropathy, and what are the usual clinical features? How would one screen or diagnose and manage these patients? BK virus is actually a ubiquitous virus, which is a DNA virus, and it's present in all immunocompetent people. More than 95% of people will have BK virus in their renal tubular cells, uroepithelial cells, but it remains as a latent virus, like a CMV virus. Most of us will get infected with CMV somewhere during the early phases of our life, and then it remains latent. And some of these patients have activation of this virus, and therefore in transplant recipients that happens. It happens much more commonly in transplant recipients than other organ transplants, although it has been described in other, especially bone marrow transplants and all that. The usual clinical features may be a subclinical kind of a disease, acute kidney injury, especially acute interstitial nephritis with rise in the creatinine. And if this is not managed early enough, then progressive deterioration of kidney function and graft loss has been described in these patients. Viruria occurs in about 25 to 30% of renal transplant recipients. So if you monitor for virus in the urine and you do a urine PCR, about 30% of patients. But viruria is a sensitive marker, but it's not a very specific marker because only about 1/3 of patients who have viruria will develop BK virus associated nephropathy. Viremia occurs in about 1/3 of these patients who have viruria, and that's about 10 to 12%. And those who have progressive viremia actually, and in fact, a PCR, BKV PCR of more than 10,000 copies correlates very, very closely to BK virus associated nephropathy. So nephropathy is a progression of viremia, which occurs in about, nephropathy is described about 1 to 10%. Graft loss initially was described as 50%, and especially by Dr. Hariharan and his group from Wisconsin when he was in Wisconsin. And but the recent papers now have suggested, and especially the one which was published in Transplant Proceedings by Dr. Hirsch. Actually, Hirsch is the one who described this nephropathy very early in post-transplant period. And in his paper in the 2019, there were 32 patients, only one patient had graft loss, and that's 3.1%. So if you pick these patients early, you should be able to prevent graft loss in these patients. What are the risk factors which predispose a patient to develop BK virus? It is, as I said earlier, it's a reflection of intensity of the immunosuppression that the patient is receiving. And that's what causes replication of this virus. And it's been thought of that this virus disease was not known, at least in the cyclosporin era and azathioprine era. However, with the onset of use of tacrolimus and mycophenolate mofetil in the early 2000s, in the early 21st century, we find that higher incidence of these infections, BKV and CMV, became well known, and BKV came onto the picture. Is being described more with tacrolimus than with cyclosporin. mTOR inhibitors have been associated with lower rates. However, any combination of immunosuppressive drugs is being described. And I find that many patients who get referred to me having not resolved, I find that physicians and transplant physicians are reluctant to decrease immunosuppression in early post-transplant period when they find BK virus viremia or BK virus nephropathy, and they usually do a small reduction in all the drugs. They reduce tacrolimus slightly, 25% reduction of maybe mycophenolate, add leflunomide. Some patients change from tacrolimus to cyclosporin, but and maybe add even an mTOR inhibitor on top. So in fact, many of these patients are receiving, in fact, more immunosuppression rather than less immunosuppression because of the fear that you might cause an acute rejection in early phases of transplant. But I think the treatment for this and the way they need to be managed is a reduction in immunosuppression, net immunosuppression. That's what this infection tells you about. The CMV infection and BK virus infection tell you about that the immunosuppression in your patient is higher. What are the other risk factors? They are older age, BK virus antibody positive. This was again brought out by Dr. Hariharan's group from Wisconsin, that if you have donors who have BK virus positive and you give it to a BK virus negative recipient, you have a higher chance of developing. Although this hasn't become a popular method of evaluation of donor recipient and donor pairs in regular transplant programs, but this is one of the factors which has been implicated. Depleting antibody usage, especially thymoglobulin, has been incriminated. Male sex, more than 4 HLA mismatches, ABO incompatible transplant. Again, all of these suggest that usually immunosuppression in these patients will be given at a higher level. Urethral stent placements have also been associated, at least in some literature, and delayed graft function. There is a decreased incidence of BK virus nephropathy, probably related to some genetic factors, polycystic kidney disease and HLA-B51. The usual initiating event is actually that under the immunosuppression, which is usually a higher kind of an immunosuppression, the virus replicates in the tubular epithelium and the parietal epithelium of the Bowman's capsule, and the persistent invasion of the virus onto the uroepithelium causes inflammation in the kidney, tubulitis, interstitial inflammation, and interstitial nephritis. And if it is not controlled at that point of time, it will progress into fibrosis, IFTA, and nephron loss, and ultimately graft loss would occur. Once in a while, it may be associated with acute rejections, but how does one identify acute rejection when you have interstitial inflammation and tubulitis associated with it? But if you have nuclear inclusions and you have evidences of either arthritis or C4D positivity or pericapillaritis away from where you find the nuclear inclusions of the virus, then you may consider an associated acute rejection in these patients. And then in those cases, you might have to treat acute rejection first and then reduce immunosuppression on a long-term basis. This slide is an important slide because it tells you about the correlation and how we can pick up, and because the management of BK virus associated nephropathy is going to be ability to pick up this virus early actually. And viruria, as I said, occurs in about 30% of the patients and usually precedes by about 2 to 4 weeks before viremia develops. But unfortunately, viruria, although some centers use this as a marker for picking up a BK virus disease, but the specificity of this is very poor, and only 1/3 of the patients will develop viremia. So many centers across the world are using viremia rather than doing it in the urine, and that precedes by about 2 weeks for the development of BK virus nephropathy. And so if one can pick up these 2 to 4 weeks earlier by regular monitoring of these, you might be able to prevent development of BK virus nephropathy. So this is important actually, that if we keep on following these patients and routine monitoring of these patients for BK virus, and this is what various tests and their specificities are. You can look at the plasma PCR, quantitative PCR, and it has a very high sensitivity, is significantly good specificity. A positive predictive value is moderate, negative predictive value is very high. But if you have a PCR quantification and the viral load is more than 10,000, that has a positive predictive value, very high positive predictive value for nephropathy. And many people are not doing a biopsy. If they have this high degree of this and there is renal dysfunction, they may not, you may get away without doing a biopsy. But we usually do a biopsy in these patients. Urine PCR, as I said, is fairly sensitive, but not as specific. Many centers do urine decoy cells, and you can pick up this early. And if you do electron microscopy of the urine, and you might see viral particles in the form of a cast called Hoffen, and that is also seen. This is a picture of a decoy cell, and you can see the intranuclear inclusions this is in the electron microscopy at the inset. And this is the Hoffen. This is a urine. Actually, these are viral microns, virions that you see across in the form of a cast. And this is very, very specific for BK virus. And this is courtesy Dr. Rajan Dugal. This is the biopsy of this patient. We showed mild interstitial inflammation, and you can see SV40 stain showing the nuclear inclusions that you see on this patient. And this is a more advanced from another patient actually, where you see fibrosis, interstitial fibrosis, and you have SV40 positive. This is again courtesy Dr. Rajan Dugal. He may be in the audience, and I would want him to make a comment at a later point. The best way for making a diagnosis and early pickup is by screening these patients, and a usual recommendation is that you do it monthly for the first 6 months. The AST guidelines suggest that you do it once a month for 6 to 9 months actually, and then 3 monthly for the second year, and then 1 yearly up to about once a year up to about 5 years. And BKV should be monitored by blood PCR, quantitative PCR, and usually if it is more than 1,000, it is considered to be positive. More than 10,000, I said, correlates with BK virus nephropathy. Biopsy usually will show BK virus, and you can do the SV40 stain on this. More than 85% of patients who develop actually are viremic in the first 4 months. So most of the centers are usually doing monitoring monthly for about 6 months, and then they do it 3 monthly. Is this screening efficacious? This is one study which looked at 200 kidney transplant recipients. This is from Dr. Brennan. TAC versus cyclosporin patients were randomized, and they received either MMF and EZA and low-dose prednisolone. And they were monitored for PCR monthly and then 3 monthly for the first year. And they found that viruria, and they considered blood PCR of more than 2,000 copies per ml. Viruria was present in about 35% of patients, and viremia in about 12% of patients. At the viremia, they MMF and AZA was stopped. Calcineurin inhibitor was decreased if viremia did not clear in 4 weeks' time. And 95% of the patients had resolution with no increase in acute rejections or renal dysfunction. And at 5 years, the graft survival was 91% to 80. Patient survival was 91% and graft survival of 80. So no difference on TAC or cyclosporin as far as the BK virus nephropathy was concerned or viremia was concerned. So this shows that screening is efficacious. Another study of 62 pediatric kidney transplant recipients, again, monitoring done every 3 months. At 24 months, 39 patients, which was 64% had viruria, but viremia occurred in only about 21%. I told you that viremia develops in about 1/3 of these patients. Those with viremia had a stepwise decrease in calcineurin, and viremia cleared in all patients, and there wasn't any BK virus nephropathy or renal dysfunction. So as far as management is concerned, there are no specific antiviral therapies which are very effective. The cornerstone of management remains reduction of immunosuppression. Usually the MMF or azathioprine would be decreased. Many centers would decrease both the drugs, tacrolimus as well as cyclosporin, as well as 50% reduction of both. These are varying protocols, but by and large, I usually discontinue mycophenolate mofetil in these patients. And you would monitor kidney functions, look for BKV PCR every 2 weeks till kidney function stabilizes and PCR starts going down and disappears. IV immunoglobulin has been used in patients, especially those who have either an acute rejection or suspicion of an acute rejection, 300 milligrams per kilogram every 3 weeks. Leflunomide is of uncertain value, but people have used it. I said that it is being used. You combine, but don't discontinue mycophenolate mofetil. And I have patients who are on now 4 drugs rather than on three drugs. Cidofovir has also been used. Is toxic. Few studies suggest that this may be used in recalcitrant BK virus nephropathy. Quinolones has not been found to be effective. Now, if you have an acute rejection along with BK virus nephropathy, this is difficult. And as I said, that if you have tubulitis away from the site of BK virus inclusions, that means you have arteritis, fibrinoid necrosis, glomularitis, pericapillaritis, C4D positive, you might consider. And in that situation, usually people would treat acute rejection and then reduce immunosuppression once the patients have responded as far as acute rejection is concerned. Now, sometimes when you reduce immunosuppression in patients with nephropathy, acute rejection might occur in these patients. 10% of people have been described to have an acute rejection. Usually responses vary depending on how severe the disease has been and what has been the impact on the kidney. If the kidney is good, then you might treat acute rejection first again and then start managing BK virus nephropathy. What do you do with a retransplant if somebody has lost graft because of BK virus nephropathy? The role of nephrectomy prior to retransplantation that hasn't been shown to be effective at all. And Nadarka from US actually looked at the OPTN and UNOS data. 126 patients who had a retransplant in BK virus nephropathy, and they compared it to regular transplant outcomes at 1 and 3 years, and they found that the graft survival and the at 1 and 3 years were exactly similar in both these groups. So there is no advantage of nephropathy in these patients. Usually when you retransplant, you need to monitor, and usually patients should have no viremia at the time of retransplantation. Induction and maintenance protocols for retransplantation are exactly, you can use thymoglobulin depending on the immunological behavior or immunological criteria of the patient. And there is no increased risk of recurrence of BK virus nephropathy in the retransplanted patients. Thank you very much. And I'll be glad to take any questions. Thank you.
Well, Dr. Mayuresh, if there are any questions, till the time you have any question, can I ask Professor Kher?
Yes.
What about the plasma cell infiltration? Is it little more common in the biopsies where the BK virus nephropathy is there?
No, I don't.
Used to say plasma-rich rejection.
No, plasma-rich rejections are a different kind of rejections. We don't understand exactly what that means, but sometimes, occasionally, you may have when you do not do stains and all that, you may have some inclusions which look, and there may be associated plasma cells in some of these rejections. But I think with BK virus nephropathy, that has not been really described as a characteristic feature of increase in plasma. But plasma-rich rejections are difficult rejections to treat, and their outcomes are somewhat different than acute rejections in general otherwise.
I have one question.
Yes.
In patients who have BKV nephropathy with acute rejection,
Yeah.
would you prefer to use IV immunoglobulin to treat the episode of acute rejection?
That's what people have tried also. That's true that people have used IV immunoglobulin as a treatment for acute rejection in these patients. Or immunoglobulin has also been used as a rescue therapy for people who do not show any decrease in viral replication of viral loads in these patients. And that's been treated. But when you have to treat it for rejections, then you have to give fairly larger doses of IV immunoglobulin, giving maybe about 1 to 2 grams of immunoglobulins going on for long.
Just one other small point. How often does BKV nephropathy occur in non-renal solid organ allografts?
It's been described with lung transplants, but much more described with bone marrow transplants. And so that's where it has been. But it's not been universally. So there is something about BK virus nephropathy that the kidney transplantation itself, the ischemia that is produced at the time when kidney is reimplanted into the recipient, that might produce changes and might sort of overexpress HLA antigens in some fashion, and then that might lead to viral replication in these patients. So there's something inherent about the kidney transplantation program itself, I think.
Yeah, probably the transplant itself,
yes.
Because the kidney is being transplanted, that is something which predisposes the patient to BKV.
That's right. That's right. And it's the donor BKV probably which is more important than the recipient BKV. That's also been talked about. That's also been talked about. But it's not practiced. It's not practiced as commonly in the transplant programs. Although Hari Haran, I heard him talk about it in one of the ASNs.
But I think the one point that needs to be re-emphasized, you already mentioned it, but re-emphasized for the audience, is the use of the monthly BKV PCR for making a very early diagnosis. I think most of us, including myself, are not doing it in most of our patients because of the cost or the compliance factor. And that results in irreversible graft loss by the time we diagnose it. I think that is the take-home message for the audience, which is very important.
Vinay, you hit the nail on the head, and I would say that I think the general recommendation is that, but I'm sure Dinesh, myself, and you now are also practicing in an area that we do not necessarily offer it to every patient. I think we should offer it to every patient.
Yes.
Some patients who may not be able to do it, but many patients who can afford to do it, we also don't offer it because generally we see poorer patients and therefore we're not using this method. And I feel that that's something which we should do. This is a practice changing kind of thing that is important. And I think early diagnosis and pickup and intervention of it only reflects, like for cytomegalovirus, BK virus nephropathy also reflects basically that the immunosuppression is higher for the patient, and that immunosuppression needs to go down.
Yes.
To make an impact on how to recover this damage which otherwise this virus will cause.
Yes.
I think if there are no questions, we stop here.
There must be plenty. So can I ask one question? Yes. So, Dr. Kher, do you think there's any sense screening the donor pre-transplant for BK viruria? Will that have an impact on the transmission, or is just the activation which was there latent in the recipient itself?
Yeah, as I was saying, you like we do for CMV, people have looked at actually BK viremia in donors as well as it's like IgG, an antibody to BK virus nephropathy, BK virus as such, IgG positive, and those recipients who are IgG, usually more than 95 to 98% of people will have IgG antibody to BK virus. So it will be, but people have sort of, Dr. Hariharan had talked about that if you have a patient who is BKV negative, then don't give him a kidney which is BKV positive IgG, similar kind of a thing like we do for Epstein B virus or for cytomegalovirus. We don't do EBV that commonly unless you're using high doses of thymoglobulin, and that's where that BV virus disease can get aggravated. But somehow this is not a regular kind of a routine which is done in most transplants. So it seems that the overall incidence of BK virus nephropathy is low if you use a reasonable amount of monitoring of these patients, and you can manage these patients effectively by just reducing the immunosuppression.
Yeah. Sir, there are actually 3 questions. So the first question is already asked by Dr. Sakhuja, which was regarding IV immunoglobulins. The second question is regarding your experience with leflunomide, because you said that the response is uncertain. So what is your experience with leflunomide, and at what maximum dose you can give leflunomide? This is the first question. Yeah.
Actually, I haven't used leflunomide in my patients at all, and so I just give two immunosuppressive drugs, tacrolimus and prednisolone, in these patients, and I haven't used leflunomide. In fact, if the patients don't respond, then I would also decrease tacrolimus in these patients, get them to lower levels of tacrolimus in these patients. So yeah, I would reduce. So I haven't used leflunomide in my patients.
Right. The last question.
How about mTOR inhibitors, sir? How about mTOR inhibitors after the transform study? Of course, it was more impressive for CMV, but it did show a good effect against BK virus as well.
Yes. No, BK virus has been shown to be, I talked about it, that mTOR inhibitors have shown a lower incidence of BK virus and CMV infections, and therefore some transplant physicians maybe change over from tacrolimus to mTOR, or maybe use low dose tacrolimus with low dose of mTOR.
Low dose everolimus. Yeah.
Everolimus. So that's been used in certain centers. But personally, is not been treating BK virus nephropathy. I haven't changed to a. I've usually kept the tacrolimus, lower the dose of tacrolimus if it doesn't respond. But otherwise, tacrolimus with steroids has been my way of managing these patients.
So the last question was regarding the mTOR inhibitors, which sir has already asked. So
I believe the message he has given, Professor K, is screening should be done. And if a person develops, you have to stop MMF, reduce TAC if required, and possibly mTOR may be a substitute.
Thank you.
Thank you.
Thank you.
Thank you very much, Professor K, for enlightening us on this important topic.
Thank you.
I think now we go to the next topic, which I will be covering. That is, are the slides? Hello?
You'll have to share again.
Yes, sir. Sir, you will have to share again.
I'll have to share again. Is it fine now?
Yeah.
Yes.
I'll be talking COVID and the kidney in renal transplant recipients. I start with a case. This is a 59-year-aged lady, a known case of hypertensive CKD. She received renal transplant in July 2012 from her son. The post-transplant course has been pretty good. No episode of rejection. Basal creatinine 1 milligram on triple drug immunosuppression with MMF and PRET. In early May 2020, that is 1.5 months from now, she started having cough without any fever or hemoptysis. She was managed in this COVID era by teleconsultation with her nephrologist. 12th to 14th June, she developed moderate grade fever, 99 to 103. And that is on 18th June, she got admitted with us because the low grade fever and malaise was persisting. On admission, clinically, she was afebrile, vitals were stable. She had Krebs in the right intrascapular region. The basic investigation showed mild leukocytosis 14.7. Otherwise, CBC urine was normal, culture sterile, LFT, KFT was normal, creatinine was 0.94, and X-ray chest showed non-homogeneous opacity in the right lower zone. Logically, the RT-PCR for COVID was done, which was positive. Now, the first question comes, if today we get a patient who is renal transplant recipient, who is COVID positive, or for that matter, any patient, what set of investigations we should do? So I'll say besides CBC, urine, LFT, KFT, we should do absolute lymphocyte count. We have to do D-dimer, which is reflective of ongoing hemostatic dysfunction, ferritin, CRP, IL-6 to study the cytokine storm, procalcitonin, usually to exclude any secondary infection, bacterial infection, and finally, X-ray chest. If required, one can go for CT scan. Well, this lady, we had on day of admission, she had lymphopenia. Lymphocyte count was 4.1%, ALC 600. Even today, the lymphocyte count is low. The D-dimers were marginally elevated. Ferritin was high. And interleukin 6, which was done yesterday, is 99. So she has got raised CRP, raised D-dimer, raised ferritin, and raised IL-6. Now, this was the X-ray. If you see, in the right lower zone, there was a non-homogeneous opacity. This was on day of hospitalization. And this is done today morning. If you see, there is a more of a homogeneous opacity, and there is a breakdown area or cavitation which appears. A CT scan shows that there is a consolidation here and cavitation, breakdown areas, possibly more suggestive of tuberculosis. Now, this is only to say the ferritin, which has been going up, D-dimer, which is going up, C-reactive protein, which is going up. So the diagnosis in this patient was live-related renal allograft recipient, basic disease, hypertensive kidney disease. She was COVID-19 positive, a moderate disease because of the investigative profile, and possibly she had pulmonary cause. Now, what investigations and what management she received? Besides, she has been on nasal oxygen right from day of admission, which is almost now 8 days. And today also she was on nasal oxygen, 2 liters per minute and maintaining good saturation. She has received hydroxychloroquine and enoxaparin. MMF was stopped. Empirically, she has been started. It was planned initially to do a bronchoscopy, but because she was positive even yesterday, the bronchoscopy was deferred by chest physician, and she has empirically been started on ATT. Tocilizumab was not given because one, patient was pretty stable, and second, more importantly, possibly there is an underlying infection of tuberculosis. That is why it was withheld. She is doing reasonably okay, but if she deteriorates, the plan is to give convalescent plasma therapy to her. This was case 1. Keep in mind that she had lymphopenia, she had low ALC, raised CRP, ferritin, D-dimer. We come to case 2. This case is given by Dr. A.K. Bhalla from Gangaram. This is Mr. R.K., 61-year-old male, who received transplant, spousal transplant in 2012 for basic disease CGN. Basal creatinine is 1.5, and he is on triple drug immunosuppression with TAC, MMF, and PrEP. He got admitted in Gangaram on 16 June with 5 days history of fever, and there was shortness of breath of 2 to 3 days. On admission, he was febrile, breathless, respiratory rate of 30 per minute, Saturation 82%, chest shows bibasal Krebs. Other systemic examination was normal. Logically, the RT-PCR COVID-19 was positive. Now, the investigative profile over this last 1 week there, the CBC, the lymphocyte count was 550 on admission, and today it is 15%. The creatinine was elevated initially 2.79, which came to normal with good hydration after 2 days. He had raised CRP, D-dimer was elevated, ferritin was high, and IL-6 has been gradually rising. Procalcitonin, which was high on day 1, became normal on second day. Blood culture, CMV, PCR was negative. So this gentleman has again got lymphopenia. He had raised creatinine, possibly a pre-renal failure. The CRP, D-dimer, ferritin, IL-6 are elevated. The X-ray showed some flary non-homogeneous opacities, bilateral in both lung fields, more peripheral. And if you see the CT, which again shows ground glass opacities in the periphery, both sides, well distributed. Well, this is the classical thing I think most of the nephrologists are seeing today. The basic diagnosis we made was live unrelated renal allograft recipient from spouse, basic disease CG and CKD, COVID-19, moderate to severe disease, AKI, pre-renal most likely. Patient was on high flow oxygen mask. However, since he was not maintaining saturation, he was put on BiPAP and remained on BiPAP for 5 days. Now he is back on nasal oxygen. He received antibiotics, hydroxychloroquine, and he received Solumedrol 80 milligram stat, and he has been taking Solumedrol 40 milligram BD. He has received enoxaparin, he is still on. He has received tocilizumab 800 milligram on 3rd day of hospitalization. MMF was stopped. Gradually he is improving, still hospitalized, afebrile, and on nasal oxygen only. Well, the questions which come with these cases are, 1, what is the clinical presentation of COVID in renal transplant recipient? And what is the mortality? What is the importance of lymphocyte count? What is the radiology? And how we should deal with the immunosuppressives and cytokines? Going one by one, if you look at whatever are the published data, the first study came from UK, which again clearly showed out of 7 patients, all presented with fever and respiratory symptoms. 4 needed ITU admission, and there was 14% mortality. Look at the second from New York, again 80% presented with fever, 56% with cough, and 40% roughly with dyspnea. Look at the Italian experience. Again, you find that presentation is with respiratory symptoms and fever. Of 25% of their patients died, and 4 of them required ITU care, which is a high mortality of 25%. Look at the Montefiore experience from New York. Again, you find fever 58% presentation, diarrhea 22%. And 11 received mechanical ventilation out of 36, which is approximately 30%. And 10 out of these, 28% died, which is a pretty high mortality. And again from New York, data of 10 patients published in AJT. Now, these are patients who have received transplant long back, almost 7-8 years back. Out of 10, 7 presented with fever, 9 were hospitalized, 5 in ICU, 3 required intubation, 30% mortality. So what we have seen with the available literature, that renal transplant recipient, possibly more of them are requiring hospitalization. And once they are hospitalized, vis-a-vis normal population, more are requiring mechanical ventilation and ICU care. And the available data shows, whether it's Italian or New York, there is a mortality of 25 to 30%. Let's come to the second question. Lymphopenia, does it project the severity of disease? There is not much data available on that, but whatever data is there, Well, this is a Chinese study of 90 patients follow-up. What they have done, they have studied the lymphocyte count at two points. One, when they were admitted at 10th day and on 17th to 19th day. They divided the lymphocyte count into less than 5% critical, 5 to 20% severe, and more than 20% moderate. What they found that people who had a drop in lymphocyte count, possibly they portrayed a severe or critical disease, especially if it was less than 5%. And this found that if the lymphocyte count was less than 5%, possibly they require ICU care. Mind you, I have shown our both two cases. Both the cases had lymphocyte count less than 5%. And fortunately, they were not in the ICU so far. So, but keep in mind, lymphopenia could be a predictor of ICU care or bad outcome. Why the lymphocyte count or lymphopenia occurs? We don't know the exact cause, but possibly maybe the virus directly infects lymphocyte, or it directly destroys the lymphatic organs like spleen, or the inflammatory cytokines lead to lymphocyte apoptosis, TNF and IL-6, or the milieu, what is created, metabolic milieu, like if lactic acidosis, etc., maybe that is causing lymphopenia. Well, let's come to the third point, that is the COVID infection and radiology. X-ray is the usual investigation which we normally do, and we should not rush for CT scan because for obvious reasons, most of the hospitals, if you are going for CT scan, you have to have a fixed time when you take the patient. Many hospitals may be having a dedicated machine for CT scan for these people. And after that, you have to clean. And if you don't have a separate area, you have to clean immediately after the case. So possibly CT will be suggestive if there is doubt left. If you see the X-ray, 70% of the patients who are requiring hospitalization have got radiological findings on hospitalization. And some develop changes during hospitalization. So 80% of the patients have radiological abnormalities when they get hospitalized. Consolidation is the commoner than ground glass opacity, that is 48 or 33%. This is from one of the studies. So what is important to know that you can get GGOs or consolidation, which is peripheral, preferably in the lower zones. If you come to the CT, this is a study which recently came, and this is a 53 patient, CT diagnosed 51 of them, 70% of them positive, they had positive CT or hospitalization even before the RT-PCR report was available. The classical features are GGO and consolidation, which is seen in almost 96% of patients. Lesions are peripheral and subpleural in majority of them. Besides GGO and consolidation, one also sees, because of the interlobular septal thickening, you can see crazy paving pattern in almost 2/3 of the patient. A minority may have air bronchogram and other features. If you have to see sequentially, what are the CT findings in adults? Ground glass opacities, bilateral, subpleural, peripheral, basal. Crazy paving appearance, GGOs, because of the inter and intralobular septal thickening. There can be air space consolidation, bronchovascular thickening, or traction bronchiectasis. If you have to go how the temporal CT changes occur, you find there are 4 stages on CT. In the early initial stage, 0 to 4 days, it may be normal 50% of the times. If you are seeing between 5 to 8 days of illness, there are increased GGOs and crazy paving pattern. The peak is 9 to 13 days when you generally see consolidation. And after 14 days, usually there's an absorption phase where there's an improvement in the disease, and one might find fibrous stripes appear and abnormalities, which we still do not know what will be the long-term changes in CT or in lung X-ray after the COVID heals. The third is the immunosuppressives, how we manage. I think the John Hopkins approach is what most of us are adopting, which is appealing and good. What the John Hopkins does, they test for COVID if there is a fever, cough, shortness of breath, loss of taste or smell, diarrhea or body ache. And that is what precisely most of us in India are doing. They admit the patient if breath holding is less than 10 seconds or if there are raised inflammatory markers like CRP, ferritin, D dimer. That is what we all practice. And they recommend that do a absolute lymphocyte count. And if the lymphocyte count is less than 1,000, reduce MMF or ESA. And if it is less than 700, like in both our cases, stop MMF, which most of the nephrologists are doing today, that MMF is being stopped. We are quite about the TAC. We generally try to maintain 4 to 6 nanogram, but if the patient is really bad and going on ventilator, it will be prudent to stop TAC, and steroids we give 10 to 20 milligram. Now, what about the tocilizumab in renal transplant recipient? This is one study which first appeared in one patient where they treated pneumonia with tocilizumab and they found a good result. This is the study, the 6 cases which were Italian study, where they again found that 50% of the patient oxygen therapy requirement decreased, and in 1/3 of them, there was improvement in radiological changes. Possibly, we don't have enough data, but what it appears that tocilizumab may be a useful drug if you have thinking of cytokine storm. This is the publication. There's no doubt you have to give it after doing an IL-6 level. You have to prove that it is elevated. This is the study which appeared yesterday only. That's a tocilizumab in patients with severe COVID patients, which only clearly shows that tocilizumab treatment, though the study is on large number of patients, 1,351 patients admitted, 40% had severe COVID. And what they are trying to say that tocilizumab treatment was associated with reduced risk of mechanical ventilation or death. So possibly there is a role for that at the moment with available data. If there is a cytokine storm, we should opt for tocilizumab. The last 2 points will be convalescent plasma therapy, which initial publication which showed that 1 dose of 200 ml of convalescent plasma, provided the antibody levels are there. What is really happening many times that antibody levels or titers are never monitored. You find patient has got antibody qualitatively and you take the plasma and give it. The initial study of 10 patients showed the clinical symptoms were significantly improved along with increase in oxyhemoglobin within 3 days. This is what you found. The CRP level came down, the lymphocytes level improved, ALT, AST, bilirubin, every saturation, everything improved by giving this. And this was another study of 25 patients which appeared, which again showed that after 7 days of transfusion of convalescent serum, 9 patients out of 25 showed 1 point improvement in the clinical scale. And after 14 days, 76% of patients had at least 1 point improvement in clinical status. You are all aware of what the clinical status ordinate scoring is given by WHO. Now, this is a paper which appeared a few days back from UK. This was on dexamethasone in hospitalized patient. And they gave dexamethasone 6 milligram dose. And what they found that dexamethasone reduced that people who were on invasive mechanical ventilation, possibly 1/3 of them, they could save the mortality. And people who were not on ventilation, but on invasive mechanical, 1/5 of the patient, you could save them. This is the early data. We really don't know. Many times we say whenever there's a viral infection, you should withhold steroids. But this study is showing this recovery trial that possibly it might have a role. And the last one, the remdesivir trial, we know trial done on a large population, which they gave this for a long time, 200 milligram on day one, 100 milligram daily after that, and they find that the recovery time certainly improves by a period of 4 days. And this is the same study which shows that the recovery of patients can improve with this. I think I'll stop here. Just to summarize, we will say renal transplant recipients are a vulnerable group. They require high hospitalization and mortality is higher. Presentation is with fever and cough like normal population. On radiology, over 2/3 of the hospitalized patients have pulmonary findings. Immunosuppression, we all know MMF is to be reduced or stopped. TAC, you have to monitor. Limited data shows that tocilizumab is useful if IL levels are rising or they are high. Anticoagulants, if D-dimer level is high, we all give it. Convalescent plasma therapy appears to be promising. I think a lot of data will be appearing from India, where a lot of convalescent plasma therapy is being used. And lopinavir, ritonavir interacts with tacrolimus. The usefulness is doubtful. And remdesivir reduces time to recovery without affecting the mortality. I stop here. It'll be a pleasure to take any questions. I think
I think we are going to take questions at the end of.
We are going to take the questions at the end.
So I'll request now Professor Sakhuja, my teacher from PGI and a superb speaker, to talk on CMV and the transplant. Professor Sakhuja, please.
Yeah, so sir, you will have to
Yes.
stop the sharing. Verma sir, you will have to stop the sharing so that we can share the slides of Dr. Sakhuja. Yeah. Anish, we can share the slides of Dr. Sakhuja. Yeah. Yeah.
Yes. Thank you very much indeed, General Verma. And at the outset, I'd like to thank Centaur Pharma and General P.P. Verma for this kind invitation to participate in today's webinar. And since it's already 7 o'clock, so I'll keep myself a little short so that we don't get too late. Now, cytomegalovirus is a member of the herpes viridae family, and it's also called human herpes virus 5. In India, infection with this virus is generally acquired within the first 2 decades of life in 90% of our population, who then become IgG antibody positive. In countries, in advanced countries like the US, only 50% of their population is seropositive for CMV. After acquiring the infection, the virus remains dormant lifelong in neutrophils, macrophages, and hematopoietic progenitors. And disease results only when the delicate host and virus relationship is disturbed by immunosuppression, which is used following a transplant. So what are the types of infection? Now, the type depends on the serostatus of the recipient and that of the donor. If you have a seronegative recipient who receives a kidney from a seropositive donor, these are the patients who are at the highest risk of developing CMV disease. This is what is called a primary infection, and the virus in these patients is obviously of donor origin. If a seronegative recipient gets a kidney from a seronegative donor, infection is very rare And the usual source of such an infection would then only be blood transfusions, particularly if the transfusion has not been leukodepleted. In seropositive recipients who get a kidney from a negative donor, you get reactivation infection, which is less frequent than primary infections, of course, and the virus is of recipient origin. And if a seropositive recipient gets a kidney from a seropositive donor, then you get superinfection where the virus can be of donor or recipient origin. And I'd like to remind you here that most donor recipient pairs in India belong to the D plus R plus category. The only exception being pediatric renal transplant recipients who could belong to the D plus R minus category. So besides the serostatus of the donor and the recipient, what are the other determinants of risk? One, of course, is blood transfusions, as I just mentioned, but not a very important determinant. The more important determinant is the nature of immunosuppression. Now, the virus, the dormant virus, has first to get reactivated. And this reactivation can be brought about by lymphocyte depleting agents such as antithymocyte globulin and alemtuzumab, which are used for induction of immunosuppression. And reactivation can also occur as a consequence of the use of mycophenolate mofetil and azathioprine. After reactivation, the virus has to replicate before it can produce disease. And replication is stimulated by both calcineurin inhibitors and steroids. Generally, the mTOR inhibitors do not do not reactivate or stimulate viral replication. Now, another factor that determines the risk of development of CMV disease is the nature of the organ transplant that is being performed. And kidney transplants have the lowest risk out of all organ transplant. So with kidney transplants, the incidence is only about 8%. With heart, liver, and intestine, this goes up to around 20 to 30%. With heart-lung transplants, combined heart-lung, this goes up to about 39%. With kidney pancreas, it goes up to around 50%. With marrow transplant, it goes up to 50 to 80%. Now, it's important also to distinguish between CMV infection and CMV disease. Now, so we call it CMV infection when we have evidence of viral replication, but we have no manifestations at all. And we call it CMV disease when we have the viral replication along with manifestations of the infection, clinical manifestations of the infection. The next, yes. Now, CMV disease can have both direct effects on the transplant recipient and so-called indirect effects. And I'll take up the direct effects first. These develop within the first 3 months if no chemoprophylaxis is being given to the transplant recipient. And there can be mainly two kinds of direct effects. The first one is the so-called CMV syndrome, in which the manifestations include fever, leukopenia. This may be associated with an abnormal lymphocytosis in the peripheral smear. Thrombocytopenia is often present. There are constitutional symptoms like a reduced appetite, muscle pains, arthralgias. And you can also get an elevation of transaminases to around 2 times the upper limit of normal. There is another group of patients who has organ-specific disease. And the most common organ to get involved is the GI tract. So these patients can present with a lower GI bleed, with abdominal pain, with diarrhea as a result of colitis, or you may have gastritis and esophageal ulcers presenting with an upper GI bleed or with dysphagia. Then there are some patients who will develop hepatitis with abnormalities in the liver functions, with presence of the virus in the liver, which is demonstrable by investigations. Then you can have patients who develop a pneumonia. Although this is relatively uncommon, this is the most severe form of CMV disease, and this leads to hypoxia, respiratory failure, and these can also be fatal. Besides these, you can also have other organs involved, such as the heart. So you can get a myocarditis, a pancreatitis, an encephalitis, and sometimes even involvement of the allograft itself. Of course, it is also possible to have a combination of the CMV syndrome and organ-specific disease at the same time. And finally, there is a subgroup of patients who has retinitis, which I'll discuss in more detail shortly. Now, what are the indirect effects of CMV disease? The most important one is immunomodulation or an immunoparalysis, which results in an increased risk of other infections such as bacterial, pneumocystis, fungal, and hepatitis C infection. There is also some increase in the risk of development of lymphomas, an increased risk of acute rejection and chronic allograft injury, greater risk of NODAT, and decreased graft and patient survival. May I have the next slide, please? Yes. So how does one confirm the diagnosis of viral replication and CMV disease? One test that was used frequently earlier was the demonstration of CMV PP65 antigenemia in the neutrophils. This is a semi-quantitative test which looked at the presence of antigen in the nuclei of neutrophils. But this is generally not possible if the absolute neutrophil count is very low. And in most centers, this test has now been replaced by the gold standard, which is the quantitative PCR, which can be done on plasma or whole blood to detect the viral load or the viral DNA. Now, I'd like to emphasize that the exact cutoff that should be used for making a diagnosis of CMV infection or disease is not really well established, because there is a lot of variation from one lab to another. So for determining the exact cutoff that should be used, you should get in touch with your own virology lab and try to find out in your setting what particular cutoff correlates with clinical disease. However, most investigators have used a cutoff of between 1,000 and 2,000 copies per ml if plasma is used for testing. In whole blood, the values are much higher than in plasma. Now, the highest loads are generally found in organ-specific disease. You find intermediate loads in patients with the CMV syndrome, and the lowest values in patients who have only CMV infection without CMV disease. And there is a subgroup of patients who, for instance, who have CMV associated GI involvement, but in whom the PCR might turn out to be negative. And this might also apply to patients who have CMV retinitis. Other ways of confirming the diagnosis are by histologic examination. For instance, of the GI mucosa, you can look at the upper GI mucosa or the colonic mucosa and detect the virus by immunohistochemistry. And in patients who have a pneumonia, you can do a bronchoalveolar lavage and demonstrate the virus in the BAL fluid. So how does one treat these patients? The first step certainly is a reduction of immunosuppression. So just as in BKV nephropathy, you generally stop the antimetabolite, that is mycophenolate mofetil or azathioprine, since some of these patients will be having leukopenia or thrombocytopenia. So obviously there is a need to stop MMF or azathioprine, depending on which one you're using. In case there is a significant leukopenia, then you can also use granulocyte colony stimulating factor to rapidly improve the leukocyte count. So the chemotherapeutic agent of choice, you can choose between intravenous ganciclovir or oral valganciclovir. And you use these drugs generally for a period of around 8 weeks at least, until the CMV DNA is undetectable. And these drugs require modification of the dose if there is graft dysfunction. So if the GFR is less than 50 ml per minute, then the dose needs to be halved in these patients. In patients with a severe pneumonia, you may also consider the use of CMV immunoglobulin in high doses because this can reduce the mortality. After this chemotherapy with the ganciclovir or valganciclovir, many centers do consider using secondary prophylaxis with valganciclovir for a period of 1 to 3 months, but there isn't a consensus on this as yet. There are a few new drugs under development and investigation for the treatment of CMV disease. One of them is maribavir, and the results of a phase 2 trial were published only last year in the New England Journal of Medicine, which showed that this drug was not inferior to valganciclovir in the preemptive treatment of these patients. What about preventing CMV infection and disease? So this is an approach that many centers adopt so as to not have to treat these patients and not have to seed CMV disease at all. Oral ganciclovir was an option that was used earlier, but this is no longer commercially available. So the drug of choice for prophylaxis is valganciclovir. Now there is a little controversy as to whether you should use 900 milligrams a day or whether 450 milligrams a day is enough. There was a small study done recently at the PGI Chandigarh, which suggested that 450 milligrams a day is enough. And the advantage of 450 milligrams is also a lesser risk of leukopenia, which can occur as a result of the drug itself and lead to withdrawal of the drug, with again an increased risk of CMV. So I personally would prefer to use 450 milligrams a day for oral prophylaxis. This should start within 10 days after transplantation. Now, what about the duration of this therapy? In D plus R minus pairs, where the risk is the greatest, the duration of this prophylactic therapy should be at least 6 months, whereas in D plus R plus and D minus R plus patients, prophylaxis for about 3 months is good enough. In D minus R minus patients, prophylaxis is generally not required. After antithymocyte globulin has been used for treatment of rejection, prophylaxis with valganciclovir may be given for a period of up to 3 months. Now the next slide, please. Yes, and that's the last slide. I'll just briefly talk about CMV retinitis. Now, this is a manifestation which occurs in contrast to other manifestations. This occurs anywhere between 6 months to 2 years post-transplant and occurs as an isolated finding. So there are no other manifestations of CMV disease. The involvement is unilateral initially, and the patient presents with impaired vision, with visual field defects. And on examination of the fundus, you find fluffy white lesions resembling cotton wool spots with or without hemorrhages. Retinal detachment may also occur at a later stage, rarely. There is generally necrosis of all retinal layers in these lesions. The diagnosis is largely clinical and is based on serial observation of the retinal findings. As soon as the ophthalmologist makes this diagnosis, treatment should be started as early as possible. You can treat with oral valganciclovir. However, if the lesions are close to the macula or the optic disc, then it's preferable to treat with intravitreal injections of ganciclovir given repeatedly, initially twice a week for up to 3 weeks and then once a week. Or you can use a ganciclovir implant, which can be replaced every 6 months or so, because this results in prolonged release of the drug into the vitreous. So this is how CMV retinitis needs to be treated. So thank you very much indeed.
Thank you very much, sir. As usual, a masterly oration, and I think we will have the question answers in the end. Now, may I request Professor Khullar to talk on, Dr. Khullar has got a large experience of transplanting HIV positive patients. To be honest, when I was transplanting my first HIV positive patient, I rang him up and asked how he goes about it. And there are many tricks involved in that. Dr. Dinesh Khullar, please. I think with your experience, you are the most appropriate person to talk on that.
Thank you very much, sir. And it's indeed an honor, and my sincere thanks to Centaur Pharma for having given me this opportunity to be amongst this most august gathering and a galaxy of stars. Important is the fact that I am today sandwiched between my teacher, whom we have all such a high respect for, Dr. Sakhuja, my examiner in DM, Dr. Vijay Kher, one of the best known nephrologists of the country, and my very dear friend, my senior from PGI, and a very inspiring figure, that's General Verma. So I'm a bit nervous amongst all these, being amongst all these stars, and I'm going to take a totally different area, and that's kidney transplantation in people living with HIV/AIDS. That's what we currently address these patients as. All the previous talks were in the context of some kind of infection which occurred after transplantation had been done. And I'm going to be talking about something little different, whereby how do we plan and manage kidney transplantation if the recipient is HIV positive. Well, HIV has long been considered a contraindication to kidney transplants. And that is because of various reasons. We always thought that these patients were already immunocompromised and they will fall in trouble. They will have a higher incidence of opportunistic infections, coupled by the fact that they are going to be now put on transplantation-related immunosuppression. Also, the fact that HIV-associated renal dysfunction is a distinct entity about which we have learned a lot in the last few decades. And also, there is the fear of nephrotoxicity associated with antiretroviral therapy. But the interest in kidney transplantation in patients living with HIV or AIDS has actually been in practice over the last couple of decades. In fact, with the new millennium, and we have now more and more centers reporting successful outcomes after transplantation in such patients. Quickly recapitulating as to what goes wrong when a patient gets HIV. Well, of course, we all know about the often quoted HIV-associated nephropathy, but mind you, this is not about all. This is there in just about 10% of cases. There are other forms of podocytopathies ranging from other forms of FSGS as well, the NOS variety. We also have other podocytopathies like minimal change disease, and also immune complex diseases starting from IgA nephropathy, lupus nephritis like illness. We have membranoproliferative glomerulonephritis and membranous, all reported with HIV. We have, these patients have a very high incidence of tubulointerstitial diseases, both related to the disease per se, as well as possibly the drugs which they receive. And of course, some vascular complications. We, as I said, the fear of nephrotoxicity, which is typically associated with antiretroviral therapy, which these patients have to take. And of course, the nephrotoxicity, which is associated with, at times, very toxic antimicrobials, which have to be used in these patients to treat their opportunistic infections. Before we go on and see whether we can really go ahead successfully with a successful transplantation in these cases, let us try and address what are the policies or the selection criteria which many centers across the world have formulated over a period of time. Well, as I said at the outset, opportunistic infections are the first things which come to mind, and most of the centers would be wary of these when they address the renal transplantation in these patients. As you can see here, Spain has a different approach as compared to UK, and so has USA. Spain will allow a previous history of tuberculosis or pneumocystis carinii or esophageal candidiasis in these patients and do not treat it as an exclusion criteria, while UK, most of the centers will not go ahead if the patients typically had these infections in the past. Similarly, USA does not exclude pneumocystis carinii or esophageal candidiasis as an exclusion criteria in patients who are HIV positive while planning their kidney transplantation. But what is consistent across all the centers performing such transplants is that the CD4 T cell count should be more than 200 cells per microliter, and the plasma HIV RNA should be non-detectable, at least less than 50. There were only one series which had reported their successful outcomes even when they accepted patients with HIV RNA count of less than 400. Well, what are the typical indications? They remain the same as we commonly see or go ahead in patients who are HIV negative. But we must ensure that their patients have no reversible factor in their chronic kidney disease, and they have well-controlled HIV for at least 6 months prior to kidney transplantation, and undetectable plasma HIV RNA, CD4 more than 200 cells, as I've already said. But interesting concept is here, where will the donor come from? Many a times you would accept at least in the Western countries where you have a more robust deceased donor program, it typically comes from deceased donors. Now, most of the times you will actually want to use HIV negative patients, but in a few controlled or trials, they have used even HIV positive patients, but will control viremia in patients who are HIV positive for their transplantation. Now, there is also a concept like many of these patients, including the donors, may have an associated hepatitis B or C co-infection. Whether to accept them also is a challenge, and few centers have actually done that, especially in the case of hepatitis C, now with the availability of good treatment against it. Now, whether would you want to go ahead with a living donor? Well, yes, as in our case also, we have a large experience whereby family members chose to donate one kidney to their family members with HIV positivity who was to undergo kidney transplantation. But most of the centers would always advocate that the living donor should be HIV negative, because we should not accept a patient who is HIV positive for donation the way we do in typically diabetics, because of the risk of their getting kidney disease in later times to come. Well, the typical contraindications where most of the centers would not want to go ahead with transplantation would be a progressive multifocal leukoencephalopathy, primary CNS lymphoma, active CMV, pulmonary aspergillosis, especially the invasive variety, Kaposi sarcoma, coccidiomycosis, and a chronic intestinal cryptosporidiosis, which has lasted for more than 1 month. While when it comes to a co-infected, I'm talking about recipient now, who also has Hep B or Hep C, we must seek hepatologist consult to make sure that there is no significant chronic liver disease before we plan such a transplant. Well, when we talk about the immunosuppressive protocols, we must have the immunosuppressive regimes balancing the risk of worsening of the underlying HIV, and there has to be that typical balance between the immunosuppression, the infection, as well as the chances of getting opportunistic infections. Induction, well, initially we thought that these patients are not going to be able to reject the organs, so we took them little lightly, and so was the case at our center as well. At least for the first 2 or 3 patients, we burnt our fingers, and we realized that once their HIV status is under control, they have very high chances of rejecting the kidney because of the immune dysregulation, and the HIV positive state is actually a continuous inflammatory state, and the immunogenicity actually gets enhanced, and they can have very high chances of rejection. That's what happened in our first couple of patients as well. So if we have used ATG, so which ordinarily we were fearing earlier on, thinking that maybe ATG is going to be a very bad thing for them, but interestingly, over a period of time, we realized that ATG caused 61% lower risk of acute rejection when compared to those who did not receive any induction, and it was far better than even basiliximab induction as well, although it's still debatable whether to choose ATG or basiliximab, but I think one should go ahead with some kind of induction in these patients. The maintenance remains the same as what we are always used to, and of course, we have all the reason to closely monitor these patients for the risk of opportunistic infections. This is a recapitulation for people who are well versed in the therapy. As you can see, we typically these days use 2 NRTI drugs, that's nucleoside and nucleotide reverse transcriptase inhibitors. We typically choose tenofovir and lamivudine out of this group. So 2 come from this, and 1 we can choose either from NNRTI, which is typically efavirenz, or maybe currently these days we go more in more favor of integrase strand transfer inhibitors, raltegravir or dolutegravir, which is very widely used, at least in US these days. Now, the word of caution here is, traditionally we were using protease inhibitors in these patients. The caution here is protease inhibitors are inhibitors of cytochrome P450, and then they tend to cause very, very high levels, really very high levels of cyclosporin and tacrolimus, and we end up using just about 0.25 milligrams or 0.5 milligrams of tacrolimus once or twice or maximum 3 times in a week. So that's the kind of levels which go up if we had used protease inhibitors. On the other hand, with efavirenz, it's actually an enzyme inducer and cause reduction in the levels of tacrolimus or cyclosporin. So again, I think currently we are much better off combining 2 NRTIs. That means typically tenofovir, whether we choose to use TDF, that's the traditional always which we were using, the disoproxil fumarate, or the more current one, which is less toxic, that is tenofovir alafenamide. And we as I said, we pick up 2 from this because we have to use 3 drugs, and we are much better off if we combine with one of the INSTI, because there is no risk of this combination as far as the drug-drug interactions are concerned. For people who are wanting to go ahead with such transplants, they must make sure that they are very thorough with the drug-drug interactions. I have already highlighted the risks. Typically, these 2 with mTOR inhibitors and CNIs with the protease inhibitors, while there is some interaction as far as the NNRTI is concerned, because as I said, they may increase the metabolism and lower the levels. But again, highlighting the same point, if you pick up 2 from here and 1 from here, there is not much cause of fear as far as going ahead safely without worrying too much about drug-drug interactions is concerned. Well, thymo can cause further reduction in CD4. We have to be careful. Corticosteroids, on the other hand, will have a tendency to cause an increase in CD4. Azathioprine can actually cause increased viral replication, but MMF actually, to our surprise, we have realized that it has some kind of antiretroviral activity as well, so can be safely continued. And same about some positive effects of cyclosporin and tacrolimus, because they may selectively inhibit the infected cell growth in case of these patients. So I've already highlighted that you will choose 2 NRTI drugs from that group, combine it with the integrase strand transfer inhibitor, and you can expect excellent graft results. And the patient survival, as has been shown in the last almost like 20 years, the graft survival is to the tune of almost 96%, barring this initial study from Kumar. And as I said, they had gone ahead with the HIV RNA of up to 400 as well. And patient survival has been excellent. So I think this dispels many false beliefs and false notions and myths about going ahead with transplantation in patients with kidney transplantation. Quickly going ahead with our patient, a 47-year-old who was diagnosed as having HIV and presented to us in 2016 for renal transplant evaluation, with the only available donor being his brother, who was actually ABO incompatible. So he was HIV RNA negative, CD count was more than 200, and he was CDC and flow cross-match negative. Here, as our experience has shown, you can actually at times expect a false positive cross-match positivity, the way we come across in lupus and other autoimmune disorders. because of the immune reconstitution which can happen in patients with HIV. This patient had luckily had a very low anti-B titers, and the transplantation was successfully done in June 17. And we used 200 milligrams of rituximab, a single dose of ATG induction, no plasma exchange because the titers were low, good graft function at discharge, which has been maintained over the last 3 years. He continues to be doing very well. His last creatinine is 1.6, and CD4 count and HIV RNA is undetectable, and CD4 count is acceptable. Well, we've done actually transplants in close to 14, and I had a data available of these 8 patients of ours. As you can see, we have lost one graft in this patient, but that is basically because of his sheer stupidity. He stopped. He's a non-compliant patient who stopped all immunosuppression because he couldn't afford it. And this patient was from Nigeria. Most of these patients have been international from the African countries, but we have one patient, the one who I've described, is from India, and he's doing very well. Most of these patients, as you can see, have maintained an excellent graft function, barring the one where the graft was lost because of non-compliance, and another one where the patient had acute coronary syndrome, developed, received bypass surgery, and then had a permanent graft dysfunction later on as well. So to conclude my talk today, kidney transplant in people living with HIV/AIDS recipients is a well-tolerated, a safe and effective treatment for end-stage renal disease. And it has been shown that, as is the case with non-HIV patients, the survival post-kidney transplantation and the quality post-kidney transplantation is much better as compared to life on dialysis. One can, as I said, expect false positive cross-match, and one has to go in for single antigen bead to make sure that we are not unnecessarily denying a transplantation to a patient which ordinarily otherwise could have been done. These recipients are at higher risk for acute rejection, and be prepared for difficult, hectic course, and it's better off to use induction, and we have relied on ATG induction and with very good results. Coexisting hepatitis C or B in these patients is another challenge, and I think the final decision has to be taken on case-by-case basis, and you have to involve your hepatology colleagues before taking a final decision. The drug-drug interactions, as I've highlighted repeatedly, is the crux of the matter, and that is where most of the times things have gone wrong. If we have not taken account of this, and there have been wide variations, ranging from tacrolimus toxicity to hardly any drug levels in the blood, accounting for rejection in these patients or TAC toxicity. With current combined antiretroviral therapy and improved understanding, we can safely conclude that we can expect excellent graft and patient survival in these patients, and there is no reason to deprive them of the benefits of kidney transplantation if they can manage one. Thank you very much.
Thank you very much, Professor Kuller, for beautifully explaining that in today's times, you can do a transplant with HIV positive patients, but one has to be very clear about the interaction of ART with the immunosuppressives we are giving. Just a question, how many days prior to transplant you start immunosuppressives in these patients?
It's the same, General Verma. I mean, we have absolutely no difference. As I highlighted, initially we thought that maybe they will not be able to reject the organ. So we took it lightly and we burnt our fingers. They actually rejected. And then we were always fearful that if we use ATG or if we use the normal dose of immunosuppression, maybe they will fall in the trap of opportunistic infection. That also didn't happen. So we are treating them the way we treat our normal patients. We start our immunosuppression exactly 36 hours, the way we do 36 hours before the actual transplantation. We use antithymocyte globulin the way we do for our other patients. That's unless it's a well-matched this thing or there is some other reason to go in for Simulec. But we would always advocate some kind of induction with these patients.
Thank you. I think, Dr. Mevresh, can we
Yeah.
take one question and answer?
Yeah, we will take the questions. The first question is from Dr. Deepak from Delhi. Do we need to stop anti-metabolites all the time? And when would you treat CMV infection? Only in the post-transplant cases? This question we can direct to Dr. Sakhuja. Yes.
Yes, I would see, because when you develop CMV disease, just as Dr. Kher mentioned in the context of BKV nephropathy, the occurrence of CMV disease generally means that the patient is excessively immunosuppressed. And CMV itself, as I mentioned during my presentation, also leads to immunomodulation or immunoparalysis and an increased risk of other opportunistic and bacterial infections. And therefore, yes, I would generally take off the antimetabolite when I'm treating CMV disease, even in the absence of leukopenia or thrombocytopenia. And of course, once the therapy is completed, that means about something like after 8 to 12 weeks, I would reinstitute the antimetabolite.
Yeah. Sir, another question for you. Should CMV prophylaxis be given in all transplant patients or only to those who receive induction with T-cell depletion agents?
Yes, this is a question that is often asked. And if you go by the guidelines, if you go by the guidelines in the literature, in the pairs in which you have a D plus R minus combination, prophylaxis is very strongly recommended in all these pairs, because these are the ones which have the highest risk of developing CMV disease. So in this category of patients, yes, CMV prophylaxis should be given to all these recipients ideally. However, in the Indian setting, and we are talking about our own setting, where the vast majority of recipients are going to be seropositive, and the donors are also going to be seropositive. So we have a D plus, R plus setting in the majority of our recipients. And in that kind of setting, even if ATG is being used, my personal feeling is that it is not compulsory to give CMV prophylaxis. However, I am aware that at least in those patients who are receiving ATG induction, and this is low dose ATG induction, just about 3 milligrams per kilogram, most centers are prescribing CMV prophylaxis for at least about 3 to 4 months. So that is what most centers are currently doing. However, my personal feeling is, based on my own experience with low dose ATG, I have seen very little CMV disease, and therefore I currently do not use prophylaxis even after ATG induction in my patients.
Right. Next question is for Dr. Kullar. In transplant in PLHA patients, is there any role of antifungals being given prophylactically?
Well, we have not changed our strategy. We routinely do not use fluconazole prophylaxis. So all that we do is the local oral prophylaxis with the clotrimazole lotion and all. But we do not give our patients, because that will pose another trouble of another drug-drug interaction. So and especially, you see, what the point I want to make is that if you are a patient of PLHA is adequately treated, the HIV RNA count is under control, is negligible, is not detectable, and the CD4 counts is way up, above 200, you can treat them like almost normal recipients, and you don't have to be overly worried about what will happen once you give them additional immunosuppression. So that's been the experience, and that has been the experience world over. So they are not landing up with more opportunistic infections as long as their viral count is under control. And that is why the treatment has been revolutionized with the availability of the more novel therapies against the virus. And now we know as to how best to use them in our patients who undergo kidney transplantation.
I think I'll put a question to Professor Sakhuja. Some centers are practicing antifungal prophylaxis for 3 months post-transplant. As Dr. Khullar rightly mentioned, at the moment, you are putting another problem of fluconazole altering the TAC levels and in decreasing the TAC levels, putting on risk for rejection also. Is there any setting where you will like that antifungal prophylaxis should be given to transplant recipients? I'm not aware that any recommendation on that.
No, at least even I agree with that. I don't think there is any indication for giving fluconazole to transplant recipients for prophylaxis, even in patients who have developed CMV disease, although they might be at increased risk for fungal infections as well. But I don't think there is any such recommendation for using fluconazole.
Plus the fact, General Verma, that there is a very high incidence of resistance against fluconazole. Fluconazole doesn't seem to work even against milder forms of skin infections any longer. So forget about, we'll be wasting a drug and always causing TAC toxicity by elevating the levels rather than.
Because I was just reviewing an article, I was surprised the authors had used antifungal prophylaxis, and sure enough, the patient had high TAC level. They precipitated fungal pneumonia. Even after fungal pneumonia, they treated the patient with fungal pneumonia. Even then, the TAC level was on a higher side, and then they caused a brain abscess. So I don't think antifungal prophylaxis is recommended in any setting at the moment. Yeah, please, Dr. Mayuresh.
Yeah, we will take the last question. This again question is for Dr. Khullar. After ATG induction, would we be able to monitor the HIV patients with CD4 counts, as ATG will affect the CD4 counts?
Yeah, so that's an interesting question, and that's something which I'd shown in one of my slides as well, that of course ATG is going to cause further depletion of CD4, but then you see the catch, and this is what we have learned. We had a consistent CD4 above a particular level before we gave ATG, and the fear was that you are going to reduce it, and this reduction could be for a period as long as 1 year. But if you are sure about the compliance, and I think that's a very important point, you should go ahead with such transplants only if you are sure about patient's compliance, that he or she will continue with antiretroviral therapy. Now, if you are sure, and that's why we've repeatedly talked about the interactions, if you are sure about the compliance that the patient is taking ART, if you are sure about the fact that you have taken care of drug-drug interactions and the range of the immunosuppressants is falling in that particular range, you can be reasonably sure that the reduction in CD4 is because of thymo, which typically happens, and what we are typically used to, like CD4 tends to disappear from the circulation within the first 1 week, comes back a bit at the end of 1 month, little further at 3 months, and by 1 year, it would have come back to normal. And that's going to be the state even in patients with PLHAs. But yes, it's a challenge. There is a learning curve. And I think one should scan the literature in detail before you embark on this journey. But it's doable, as we have learned, and we've had some very good results in these patients, and even in the 4 or 5 patients where data was not available for the paucity of time, they've done exceedingly well. So maybe I would say out of these 14 patients, we've lost one patient and maybe 1 or maximum 2 grafts over a period of 5 years. The others are all doing fine.
But Dr. Khulla, do you agree that in these patients, the risk of acute rejection is higher than normal people?
Yes, so that's the paradox.
Survival is coming almost equal to non-HIV patients. But however, a meta-analysis recently published last year, the acute rejection episodes are higher. You are correct.
Yes. So absolutely true. Contrary to the belief that acute rejection will be low because they will not be able to mount in a response and reject the graft, but to the contrary, the acute rejection episode was high. That was in the era when people were not wanting to use ATG. And luckily, most of the times the acute rejections, even if they happened, were responsive to treatment, and the graft function returned to normal or near normal. So as there have been series like one from Stock et al., 150 odd patients followed up for over 3 years, the graft survival as well as patient survival has been over 90%. So you can say that yes, the acute rejection incidence is high. That is why you should use induction. That's why I would say, and I will stop there, that yes, definite some induction. Personally, we choose ATG because we have had no problems with ATG use in patients with HIV, and it has definitely given us good results. So I would continue to use. But yes, one has to be very careful, and typically the acute rejections in those patients happened in the first decade of this millennium, when people were not too sure as to, they were not very meticulous in monitoring the levels. And the levels would be something like 60 of tacrolimus down to 2, and that kind of range. So as I highlighted, that typically when you're using protease inhibitors, the dose would be 0.25 milligrams once in 2 or 3 days. But ever since we have stopped using protease inhibitors, and the newer one, the INSTI drugs, which have been now the raltegravir and dolutegravir, so they have revolutionized with 2 NRTIs and with NCT, as I've repeatedly highlighted. There is virtually no drug-drug interaction, and the results have vastly improved in the last 5 or 10 years.
So that's all about it. No more questions.
I think it was from our side, a wonderful discourse given by all the respected teachers. Professor Sakhuja, he gave a masterly talk about CMV, and Dr. Kher also before going. And importantly, what they stressed is both these viral diseases, which occur preferably in the initial 6 months, are a result of over immunosuppression. So one has to be careful, and in BK virus, a monitoring is indicated. Dr. Khulla did mention clearly that possibly today, with the new antiviral drugs, which do not have any interaction with the immunosuppressives, we expect graft and patient survival is almost similar, and even acute rejection episodes are not going to be there. Today, we can treat all the HIV positive patients as the normal population. And we also discussed about COVID and in renal transplant recipient. This is a learning phase, and most of us are learning about this disease, and we don't know how bad or good it behaves. I think before we close, I'll ask Dr. Khulla also, which will be the specific indication or what indication they choose in Saket for giving convalescent plasma therapy to these patients.
So I think before answering that, let me compliment you, General Verma, for an excellent talk. I mean, you've been praising others, but then the fact remains that we were witness to an excellent talk from you. You covered the very contemporary topic in the best possible manner. Well, you see, the question asked, we at Max Saket were among the first centers across the country to use convalescent plasma, and we have had some excellent results. I truly believe that many precious lives have been saved with the use of convalescent plasma. This is what our critical care team tells us, and the blood bank has done a fantastic job. Answering your question, I think we should not be missing that window period. That's very, very important. I mean, we must now try to figure out and predict the tsunami. That's the cytokine storm which is coming, rather than becoming too late and then probably we've missed a bus. If these patients come on a stage of ventilation, I think it's going to be too late, and not too many people survive if they have to be put on ventilators. So I think, of course, it should not be a knee-jerk reaction that every COVID positive patient should receive convalescent plasma. But no, any patient who is not heading in the right direction, like the disease moving from mild, moderate to just about the severe variety, going by the IL-6 levels, going by the D-dimer levels, and there, of course, what you highlighted, the simple diagnostic, the absolute lymphocyte count, we should be not be delaying the treatment as far as this is concerned. And we are talking especially in the context of our transplant patients. And I think transplant as well as our dialysis patients, their immunity as such is low. And even though we in India believe that COVID so far has not been a huge killer the way it was in the Western countries, but I think the final word is not out as yet. We don't know which way we're heading in the coming weeks. So as of today, we can't take this virus lightly, and especially pick those patients who are showing any kind of deterioration in their hypoxia levels, in their IL-6 levels, in their D-dimer levels. And I think one should choose, because there was controversy, there was non-availability of the convalescent plasma, and I think the awareness is becoming more and more now, and we have larger pool of donors available to us, and the indications are becoming more clear-cut. So I think it's a wonderful therapy, and we must use it.
I think very rightly, Dr. Kuller has absolutely brilliantly explained that it is a total comprehensive care. You have got the levels on one side, but if you feel that the patient is gradually deteriorating, requiring no oxygen to nasal oxygen to NIV, and that is the time you must interfere. And especially if a person has got underlying infection, like our patient had tuberculosis, or somebody is having a concomitant infection, in that setting, you may not be able to give tocilizumab and all. So those are special conditions where you should try this. And if you try it at the right time, possibly many more lives can be saved. I think I'll request Professor Sakhuja to please close the session. And from my side, I thank Dr. Kuller, Professor Sakhuja, Professor Kher, and certainly the Centure Pharmaceutical for arranging this beautiful seminar and webinar. Professor Sakhuja, kindly close the session, please.
I think it has been a wonderful learning experience, even for me. I'm a student as much as all the others who have been listening to this webinar. And so I would really like to thank all my co-speakers, and in particular, I'd like to thank General P.P. Verma and Centure Pharma for having organized this excellent webinar. Thank you very much indeed.
Thank you very much.
Thank you. Thank you very much, everyone. Thank you, Centure.
Thank you. Thank you. Thank you, sir.
Thank you.
Thank you. We can close the session.
Thank you, Dr. Mayuresh.
Thank you, sir. Thank you. Thank you, sir. Thank you.
Is it mute now?
Yeah.